Hello and welcome to Raider HQ After Dark. I'm your host Raider, and in today's video, we will be talking about the thoracolumbar spine. More importantly, how it's rated, what it entails, and what the DBQ looks like, and how each of these aspects of the rating decision are mirrored onto the DBQ itself. Now, I will start out with one caveat in that I will not be discussing the diagnosis of intervertebral disc syndrome, IVDS. That will come in a separate video because all of the rest of the diagnosis of the thoracolumbar spine, strains, sprains, all those stuff, they all behave the same way. IVDS, however, behaves in a much different way to the point that it's almost a completely different set of rules, regulations. So that's why I'm separating it out. So if you have the condition diagnosed of IVDS, that will come with a subsequent video. But however, we will be talking about the thoracolumbar spine in today's video. So let me go ahead and share my screen if I can make it work. Okay, and we'll go ahead and do a little bit of wizardry there. So this is the 38 CFR Part 4, the rating scheduler for the spine. Okay, and I don't know if you can see here, but the diagnostic codes, there's a completely different section below this that addresses the intervertebral disc syndrome. So that's why it's going to be separate. Now, if we want to come down here, they have a few caveats and notes. These are always important when you're reviewing for the the rating scheduler. If you're kind of reviewing for yourself, if you do a private DBQ for the back and you're kind of wanting to make sure that all of your private DBQ evidence lines up with it, it is always important that you not only just review what the rating criteria is up here for like what 10% looks like, but that you always also come down here and review for the notes. And I want to make an upfront statement that not many people have successfully been able to actually link bowel and bladder impairment secondary to the lumbar spine. And I don't understand why a lot of examiners report that it's not a possibility, but I would just use note number one as, if you do a higher level review for it, if you get denied for that and they say it's not possible, I would, use note one in the general rating scheduler under the spine as one of my key points to tell the DRO, because if the VA accommodates for it and tells the rater how they should appropriately diagnose such a thing, then it's true that it can be associated. So that's just kind of a tip for individuals out there because, the note sections matter. This is talking about like note two here is talking about like for compensation purposes, normal, what the degrees mean, right? Like basically giving not only the exam, like the rater a definition as to how to interpret the DBQ's measurements. Okay. Note three. Uh, this one I don't like. The examiner may state that because of age, body habitus, neurological disease, or other factors, not the result of the disease or injury of spine, the range of motion of the spine in particular individuals should be considered normal for that individual, even though it does not conform to the normal range. What they're basically saying here is that you can have impaired range of motion identified on the DBQ, but that the examiner can also qualify that that range of motion is normal for somebody your age or somebody with your neurological condition or things like that. So the reason why note 3 is very very important that you should come to terms with is because you might see the range of motions impaired on the DBQ itself and go, oh well, that gets me, that'll get me the, let's just say 20%. It gets me the 20% rating because I meet that criteria. However, you have to read the fine print and read the examiner's notes to determine that they didn't actually say that this range of motion based upon your age is normal for you. That yes, you are impaired to this degree, but that is normal for your age. This helps out with being able to, number one, effectively fight an appeal because you could go to a different doctor who says, no, that range of motion is not normal for somebody with that particular, habitus or neurological condition. It's where do they get that from? That's not anything that's true. I'm not projecting that that would be the case, but I'm saying that that would be a good avenue for you to fight that, right? If you fight, hey, look, they didn't give me my percentage because I have this much impairment. If you do a higher level review for that, the DRO is going to look at that and go, okay, well, right there it says that that's actually you're normal, so 0%, right? Normal based upon your current predisposed spinal issues. So I just pointed out, that the notes section is important, not just to the rater who rates your claim, but also to you, the veteran. So that way you are deeply informed as to what's going on so you don't get surprised by the impossible. Like it's impossible. I have the measurements, right? Well, technically you can be overruled by the examiner. So just please keep that in mind. And it also applies to private DBQs because if your examiner accidentally says that, oh no, this is normal for his, body habitus or whatever, that will just, that's going to be something the rater takes into consideration. And note 3 allows us to overrule the whatever the range of motion issues are. And if you had painful motion, then you would get 10% over 0. But if you didn't have painful motion and you just had impairment of range of motion and your private examiner accidentally says something like that, then that's going to be something that can be used against you. This is just for us, round each degree to the nearest 5 degrees. Not really impactful too much. Maybe if you're on the cusp of going from 10 to 20%, they didn't round up, then sure, for VA compensation purposes, unfavorable ankylosis is a condition. Okay, this is just basically defining what unfavorable ankylosis is and what favorable ankylosis is. This is good to know. I mean, it honestly is. It's good to educate yourself. 6, separately evaluate disabilities of the thoraco and cervical spine segments, except when there is unfavorable ankylosis of both segments, which will result in a single rating. Now, this is important, right? Like favorable ankylosis, right, of each spine can be separately evaluated. But if there's unfavorable ankylosis of both the neck and any aspect of the thoracolumbar spine, then we have to combine them into one. So this is a situation where 2 separate ratings would become 1 rating and not necessarily in your favor. So just keep that in mind. And then that's about it for the notes. So let's go up here and let's talk about the actual, what it takes to get a 10% rating. Now, the part that I started out with is I had said that there's going to be, a little bit of confusion about how this rating process works because for whatever reason, they combined the neck and the thoracolumbar spine into the same thing. So half of this talks about the neck and half of this talks about the cervical, well, the thoracolumbar spine. So we start out with talking about the thoracolumbar spine. So the way that you need to consider this is if you were standing up against a wall, how far could you bend forward? That's what they care about in this particular section of the rating criteria. They don't care how far you can bend to the side. They just care about how far you can bend forward. So you would actually need to kind of get the degrees out and say, can I bend forward 60 degrees or up to no greater than 85 degrees? So if you are able to bend halfway over, right, that's 90 degrees. If you can bend 90 degrees or more to try to touch your toes, then you are not 10%. If you, equate to 60% or 80 degrees, I should say degrees, 85 degrees, then that would score you the 10% evaluation. Now, even though we have an or here, this or doesn't apply because next we're talking about the cervical spine. So it's this or right here that counts for the thoracolumbar spine. See why it's confusing? Yeah. So, or, bending forward to that degree level that we talked about, or combined range of motion of the thoracolumbar spine greater than 120 degrees, but not greater than 235 degrees. Okay. Now, this right here I'll be able to show you kind of how they combine it on the DBQ whenever we go over it. But just keep in mind that the addition on the range of motion would be no greater than 235 degrees, but no less than 120. Because if it was less than 120, it would be on a higher scale. Or, So one of the things that I would like to take the time right now to say is that, when we talk about the DBQ, we use the worst, most impaired range of motion as your final answer. So if your normal range of motion is X and your repeated use over time is Y, that's a little bit impaired, and let's say your flare ups is Z, I'm just going just categorically. Let's say your flare ups are the most restrictive range of motion. We will go with that. Whatever the most restrictive range of motion turns out to be is what we're going to use. So when we do these calculations, it's based upon the most limited range of motion. Okay. Now, there are times that the examiner will not do certain ranges of motion, okay, on the DBQ. And that could be because, number one, it could be contraindicated, which, just basically means it's medically ill-advised because they could hurt you more. Like, let me give the example of you had back surgery recently. They're not going to want to reef on you to cause you more pain and potentially re-injure you. So that might be a situation in which they're not going to do some of the tests if they find that it's contraindicated. But let me go back here. And then we have another or, which needs to be disregarded because now we're talking about the neck again. And I'll do one of these for the neck also. But then we come down here to this or. Now this or, so far none of these have been and. They've all been or. So you can get 10% this way. You can get 10% this way. Or you can get 10% by having muscle spasms, guarding, or localized tenderness not resulting in abnormal gait, which means abnormal walking. Gait means walking, or abnormal contour of the spine. Think about like muscle spasms that have caused that cause you to have your posture shift permanently. That kind of maybe makes you have scoliosis, lordosis, or kyphosis of some kind. Some kind of movement of repositioning of your spine in a very unnatural, non-anatomical position. Okay, and then we come to another or here, which applies to both the neck and the back. Vertebral body fracture with loss of 50% or more of height. This seems like a more extreme thing, right? So if we're looking at probability, the forward flexion has the highest probability of being what you're going to be granted 10% on because it's easier to show that. Also, muscle spasms and guarding, if they just exist, will get you 10%. Okay. So that's the 10%. And we're at 14 minutes now, guys. So this is why I removed IVDS out of the equation, was because I would have been here for 2 hours. Now, forward flexion. Okay. Same kind of every other one type situation. So it's similar to the 10%, but they've just reduced the flexibility, 60 degrees to 30 degrees. Same thing. And then we come down here to the same or situation, just more of the same, where there's less overall movement of the spine, side to side, obliquely, all that kind of stuff. And then we come down here to a change of muscle spasms or guarding severe enough to result in abnormal gait. Then we have another or here. abnormal contour of the spine, such as scoliosis, lordosis. Okay, so I guess I'm going to restate what I said down here. This is abnormal contour of the spine not resulting in the permanent disability of scoliosis, reverse lordosis. That would be the 20%. So I stand corrected. Or abnormal kyphosis. And that's just, yeah, kyphosis is typically the neck, I want to say. Now we come up here to 30%. Okay, this is only for the neck. So 30% can only be gotten for the neck. You can get 40% for the thoracolumbar spine. So we skip from 20 to 40. Unfavorable ankylosis. So that's like a freezing of the spine in an unfavorable position is the way that I would describe it for the cervical spine. Or, see, this is why I hate this, is because now they start with the cervical spine and then they go into the thoracolumbar. They start with the thoracolumbar down here. It just drives me nuts. Okay, so the one for 40% for the thoracolumbar spine, as I regain my composure, is that 30 degrees or less of forward flexion. So imagine, once again, you're with your back up against the wall and you try to touch your toes, but you can only go to less than 30 degrees forward. Or favorable ankylosis of the entire spine. Now, how can you have that happen? So sometimes you can have it to where you get fusion of the thoracolumbar spine. You get a fusion of the spine, and it just restricts you to where you're sitting straight up all the time. Like that would be it. That would be favorable ankylosis, because if you're sitting straight up, you can walk normally, you can sit normally, you can do a lot of things normally. So that's the 40% criteria for favorable ankylosis. And the favorable just literally means that your spine is fused, but it's fused in a optimal way. It's not like you're trying to bend over and touch your toes and that's where your back fuses. That would be unfavorable ankylosis. And then we have unfavorable ankylosis of the entire thoracolumbar spine. So this would be the instance where your back is fused to where you can never sit up. You are currently, like whatever position it's in. And the unfavorable ankylosis is determined by the examiner and by your medical professional. So if you have a medical professional identify that you have unfavorable ankylosis of the entire thoracolumbar spine, then you could qualify for the 50% service connection. And then this one could be of the neck and the back, where you have unfavorable ankylosis of the entire spine. However, the neck and the back would be rated together at 100%. But if you had two separate conditions, favorable ankylosis or even unfavorable ankylosis of the cervical spine and the thoracolumbar spine, they could be rated separately. So, I mean, honestly, it's not, you can get 100% for this, but it's not like ideal. This would be a horrible circumstance. It would probably be easier to get 100% different ways. I mean, not that anybody's seeking that out. Obviously, if you qualify, you qualify, but just understand that there's most of this is outside of the rater's hands. Like, I have to take the examiner's word for whether or not the ankylosis is favorable or unfavorable, unless there's evidence to the contrary, right? If there's conflicting evidence, then I would send the decision back, defer the decision back, and ask the examiner to please clarify the conflicting evidence and rule one way or the other whether or not you do or do not have unfavorable or favorable ankylosis. So it's not the rater's decision. So if you do have an issue, with a claim that you have, that's the examiner's issue. So that is the 38 CFR for the spine. So let me go here to the DBQ real quick. And that's probably not ideal. Let me see if I can make it. Yeah, there we go. So you can get these off va.gov, if you're going to go with the private DBQ option, or if you wanted to just print this out to review what's going to be on the exam, I always recommend that. So you would just Google, or either go here to vabenefits.gov for the thoracolumbar spine, or you can just Google VA DBQ back. And it's going to be pretty straightforward here. The examiner just provides this information. Diagnosis, honestly, your diagnosis is based upon, minus the ankylosing type issues, but for the most part, IVDS is the one that I said that I'm not going to be talking about this video, but all of these other diagnoses, for the most part, are do not affect the outcome of your examination. What does is the symptoms, like how far forward you can, like what those look like. That's what's going to determine what your percentage is. Okay. Now, other diagnosis here, some of the things that I'd like to see are like bilateral radiculopathy, if that's the case. Um, does the veteran have flare ups? Now, this is important, okay, because um, if there's a confliction here, if yes, we're going to flare-ups are the opportunity for the veteran to discuss with the examiner what the worst case scenario looks like for them, of like when their spine is at their worst. If you are not experiencing a flare-up at the time of your examination and you do have flare-ups, you need to report that to the examiner so they can mark yes here. And the reason why is because the examiner will have you kind of mimic, like, okay, well, during a flare-up, how far forward can you go? And they kind of measure that, and they have to take your word for it for the most part. They can have their own difference of opinion. Like if you have, let's say, lumbosacral strain, and you say, well, I can move 5 degrees. Okay. Medically, they might question that and go, okay, why? Like what mechanism causes you to only do 5 degrees? That's might turn their malingering, uh, you know, review on to see, okay, well, why, give me an example of what that looks like why you can't do that. But anyway, so this has to be, if you have flare-ups, this should be marked yes, because if it's marked no and the rater gets a hold of it and they go down here later on and they talk about flare-ups, this might cause some issues with the rater to go, okay, well, you gave us conflicting evidence here. You said no here and then you said yes later on. Why did that change? Now, um, functional impact or loss. Okay, so this and the DBQs are kind of hard to understand. So this is the initial standard range of motion, right? This is your baseline. Now you can start out with an all normal baseline. And if you remember, I said we will go through and we will discuss, or we will take the worst set of range of motions and apply that. So if this is all normal, don't take it as being a bad thing, because we'll use the worst case one. Now, typically what you'll see is if this is all normal, these are the range of motions here. And I'm sorry, my dog is snoring. So if you hear that, I apologize. But like normal range of motion would be like 90 here, 30 here. See how this is the normal range of motion that's provided. So if they were to mark all normal, right, all of these would match. It'd be 90, 30, 30, 30, 30, and 30. Now, how you get painful range of motion or pain upon movement is if you report painful motion, we will take your word for it. If the examiner marks any of these boxes, we will take your word for it. And that's a minimum 10% rating. Now, if they're abnormal, what I would expect to see here is anything that doesn't match that 90. So if it was 80 here and 30 across the board for all of these, and every time I tab, it's weirding me out, okay? But 30, right? So this would be abnormal. Now, this portion, passive range of motion, doesn't apply to us. We don't really use any of the passive range of motion. This is important to note, but it's not important for the rating decision. So the next part is that the rater will take up is the observed repetitive use. Okay, that's the next section that we use in our kind of evaluation when we put it into VBMS. Now, if you have a contraindicated medical condition, like let's say you recently have surgery and you can't do this, well, they would mark no. But typically, if you don't have surgery or some kind of contraindication, they will mark yes, and then we come down here and we go here. Now, private DBQ veterans that are using the private DBQ option, one of the things that I see that causes me to discount your DBQ is if this is better than your normal baseline range of motion, right? So if your baseline range of motion is 80, 30, 30, 30, 30, 30, and we come down here to the repetitive use and you're at 85, 30, 30, 30, 30, that's going to weird me out because I'm going to say, okay, well, how can, if you use how do you get better using it more often? That seems to be, it seems like this was erroneously an error. So we will maybe not use that. Now, that in and of itself wouldn't disqualify a private DBQ for me, but I would start to go, okay, is it better whenever you use it multiple times? Like the baseline range of motion should be the best it looks like, and then it should slowly degrade as these tests move on. So my word of caution is please review your private DBQs to make sure they make sense. And as the obviously it has to be true for you, but as these tests, these range of motion tests go on, what we're expecting as raters to see is this number keep going down, right? You can't have flare-ups that are better than your normal range of motion. I've actually seen that. And it's full stop. Sent it back, was like, hey, look, tried calling the examiner, couldn't call the examiner. I'm like, look, these numbers are all over the place. I can't, it raises the question of authenticity, right? Because I don't even know if the person looked at this human being. The next set of range of motion is repeated use over time. Okay, so this would be like the multiple times, but it's got the same criteria where they'll select pain or, like what are the impairments to the range of motion, pain, weakness. The only one that matters here is pain. Fragility, weakness, lack of endurance, those equate to no additional rating criteria, so it doesn't matter. So what we'd be looking for here is like maybe like 60%, 60 degrees. Sorry, I keep saying percent, 25, 25, 25, 25, whatever that is true for you, right? The 60 is, remember, the 60 is going to be what gets you to, the low. This independently can get you to a higher percentage, or all of these added up together can get you to a higher percentage, potentially. And then we have flare-ups, right? So flare-ups, this is where, once again, if they say yes here, but they said no above, this could cause some problems. And then flare-ups, estimate range of motion, right? So keep that in mind. It's an estimate. So whatever you guesstimate, be truthful and honest, but they're going to write down the range of motion that's a kind of a guesstimate. And then, so this would be like, 50 degrees, or whatever, and 20, 20, 20, and 20, and 20. Sure. Now, because this is the worst one of the bunch, I'm going to use this one. This is the one I'm plugging in. I plug in every single one because there's a spot for every single range of motion in VBMS for all the different flare-ups and the repeated use over time and all that. So I'm just going to manually put in all these numbers, and then the computer's going to pick the one that's the worst. Now, guarding and muscle spasms. Remember, this is the part right here where you can get the 10% through this means right here, through the contour. Same thing with the 20%. 10 and 20%, this section of the DBQ can actually do that for you if your range of motion is actually fairly normal. So what they would do is they would say yes here, localized tenderness not resulting in so this would be 10% right here, as evidenced by, localized tenderness not resulting in abnormal gait. So this one. So that's what this question asks you. Now, when we come to muscle spasms, you've got the result. This is 10% right here, not resulting in abnormal gait or contour. And this is 20%, resulting in abnormal gait or abnormal spine contour. Right? Muscle spasms or guarding, not resulting in abnormal, and then the same one up here, muscle spasms that result in abnormal gait or contour. Okay, easy peasy. Same thing with the guarding. The guarding and the muscle spasms are exactly the same. The examiner checks this box, you get 10%. The examiner checks this box, you get 20%. Additional factors contributing to the disability are not relevant to the rating process, so this portion of the thing doesn't matter. And then we start getting into the strength test for the radiculopathy. So the rest of the DBQ is pretty much radiculopathy. Yeah. And then we go down here. We have the IVDS section, which is a completely separate section. We'll talk about this in a separate video. Assistive devices don't really factor into the equation. Anything down here, we do review for what's in the 14A section. So any comments section, the 14C also. Any scars like this, if the examiner marks yes to this, they're supposed to do a DBQ. But if you do a private DBQ, and let's say you had back surgery, and the examiner says that yes, or your examiner for the private DBQ says yes, there are scars, due to the back surgery, we'll grant you 0% for scars, but we will not get a DBQ for the scars unless you explicitly claim the scars. But you'll get granted at 0 now, which is fine. But if you have painful scars, it would behoove you to kind of report that and claim the scars with your spine claim. And then diagnostic tests don't really matter for the rating decision unless there's like a vertebral fracture. This one right here, if you remember, 15D is the question that gets asked for 10% for this one. So, which I find to be odd that a vertebral fracture with loss of 50% or more of your height is only 10%. Like that would be crazy. I don't think it's height of the overall person. It might be height of the vertebral body, where the vertebra is half as big as what it was, because I can't foresee. Yeah, that's what I'm going to go with, because it would be science fiction horror movie if that was true. So keeping moving here. Obviously, private DBQs, guys, you want to be checking what the examiner has written here to make sure that it is factually and true with your evidence, right? You don't want them to make an offhanded comment that kind of goes, yeah, but he goes running every single day and he seems fine. Like, no, please don't do that, because I'm going to read that and I'm going to go, wait a minute. He just told me up here in this top section that he can barely move. He's got 0 degrees of mobility, but he goes running every day. How's that feasible? How's he stand up? How's he get in the car to go there? I have questions, like, don't make me have questions is my thing on private DBQs. Make sure that everything's dressed, that it makes sense, that everything matches up. If you have limitation of range of motion, don't tell me you're going out and doing jumping jacks and, toe touches and weird crap, like it doesn't help you at all. But anyway, that's about all I got for you on this video. Let me see here. I provided, these are examples of addressing like neurological impairment. I think I just brought this up because I wanted to talk about like when, I guess the main thing I wanted to say is that the rating activity should evaluate spinal stenosis and grant service-connected bilateral radiculopathy with the effective date assigned based upon the receipt of the claim for increase. What I was saying here is we will automatically raise, if you are granted for a spinal condition and we find new evidence of radiculopathy, we will grant the radiculopathy, even if it's been previously denied, because it's what we consider a within the scope condition, because the radiculopathy has a built-in medical opinion, right, for on the DBQ. So when we come down here, it'll say, does the veteran have radicular pain, signs and symptoms due to radiculopathy? If this is marked yes, and they provide us with a checkbox for which nerves are affected, we will raise that to issue. You don't have to explicitly claim it. What happens with neurological issues is later on, after they've been initially reviewed, they will be reviewed on peripheral nerve DBQs. But for the initial assessment, that is done on a spine DBQ. That is why it can be extremely dangerous if you are an individual with 40%, with, let's say, even above 20%. Like, let's say that you have 40% for your thoracolumbar spine, and you've never had any kind of neurological conditions claimed beforehand, but you got them, what's going to happen is you're going to get a new exam for your spine in order to review for the radiculopathy. So if you don't want your spine to be reviewed, you can't bring up your radiculopathy because it will be done on a spine DBQ, whether or not you want it or not. So your spine will be brought back into issue to be readjudicated potentially if it got better. So I'm just throwing that out as a cautionary tale. But anyway, I guess that's all I kind of wanted to talk to you guys about today. We're doing the live stream tomorrow, so it's 35 minutes in. I'm just going to cut this one short. The spines are hard. The neck's going to be the same. But anyway, thank you to all the members, all the raters, and the VSRs. Thank you to everyone that liked and subscribed. I appreciate y'all. And I'll be talking to you guys tomorrow. So, Raider out.